Are you there? Okay, madam, we are live now.
Okay, thank
Shall
you.
we start?
Yes.
So, good evening, doctors and all the participants. I Shumon on behalf of Shield Healthcare, welcoming you all in today's Prayaas program on the special occasion that is endometriosis awareness. As we all know that March month is the endometriosis awareness month. So, now it's time to introduce the program director, Dr. Jyoti Vanguwala madam. Madam is the vice president Indore Ops and Gynae Society, and she has more than 26 years of experience. She is the secretary in Ops Gynae Society 2021-22, and her keen interest in ethical and methodological aspects of Ops Gynae. She is the executive member of IAEC in 1921. She was the executive member study of female breast committee 2017 to 22, executive member in practical obstetrics committee 2021 to present. She is the IMA representative for the MTP committee Indore, treasurer AICOG 2022 Indore. Coordinator medical.
Okay.
Okay. So with this short introduction, I request our today's program director, Dr. Jyoti ma'am, to take over the session and for further proceedings. Thank you very much.
Thank you.
Over to you.
Thank you very much for the generous introduction. And I welcome on behalf of the Prayaas webinar to you all, and happy Gudi Padwa, Ugadi and Chaitra Navaratri to you all. As you all know, the March is the endometriosis month, and the National Endometriosis Awareness Month was an initiation taken by the Endometriosis Association in 1993. And this month is observed worldwide through various activities that involve educating people about the condition, fundraisings, and march. Yellow ribbons and brochures are distributed worldwide to honor National Endometriosis Awareness Month. And we are so honored to have our National Committee Chairperson, Dr. Asha Rao Madam, with us for this webinar. And this Prayaas webinar we designed when in the COVID time, I made few videos and talks for some corporate hospitals. And that time we thought, why not to make some videos whole around the year to raise the awareness about the different topics for diets, for diseases, for the doctors and even the non-doctors. And so this our Prayaas webinar, it is always going YouTube live, and it is always means you can see whenever you want to see. And this is just basic introductions and basic knowledge for all the people, even the general practitioner, general whoever is logging the YouTube, she or he can understand a little bit of the disease. And that is our motto, to spread awareness about the diseases we talk about. And I am very thankful to you all. Being the new year, you all are so busy at your home, but still you accepted this invitation. And especially, I want to do this webinar just for the endometriosis awareness, though it is a very less talk topic. And Asha Rao Madam is so generous, and she is extensively traveling Dubai and everywhere, and she accepted this invitation. Thank you, Madam, and thank you, everyone. And I welcome our two esteemed chairperson for the talk of Asha Rao Madam, Dr. Ginni Gupta Madam and Dr. Anu Chawla Madam. Sumanji, please, slide deck, please show the slide deck for Ginni Gupta Madam. And Dr. Anu Chawla, she is specialist in reproductive medicine. She is editor, International Journal of Human Reproduction and Research and Development. She is editor, International Journal of Fertility, and she is North Zonal FOXI Coordinator in 22 to 23. She is Additional Joint Secretary, ISAR, New Delhi. She is member, Endometriosis and Infertility Committee, FOXI. She is member and chairperson, various infertility committees and association of ASRM, ESHRE, BFS, ISAR, and FOXI. We welcome you, Anu. Our next chairperson is Dr. Ginni Gupta Madam. She is Chief Gynec Ops in the Healthline Hospital, Ludhiana, Punjab. She is MD FICOG, ex-PGI Chandigarh. Her special interest in safe motherhood, high-risk pregnancy, and adolescent gynecology. She is General Secretary, Ludhiana Ops Gynae Society, and member of SMC at FOXI. She is she got the Manyata Champion Award and coordinator of Punjab, member SFM, member All India Women's Federation, and has delivered numerous lectures and invited as faculty at various webinars in national and state levels and various conferences of national and state level. I request Dr. Ginni Gupta Madam to introduce our esteemed speaker, Dr. Asha Rao Madam. Sumanji, kindly play the CV of Asha Rao Madam. Ginni, mic is handed over to you. Ginni, you are muted.
Please.
Madam, you are mute.
Ginni, you are muted.
Dr. Ginni, you need to unmute yourself.
1 minute. Thank you. Am I audible?
Yes, yes.
Good afternoon, all the esteemed faculties present here. It is my proud privilege to introduce Dr. Asha Rao, who is MD, DGO and Fellow of the Indian College of OBGY. Madam has such a big resume.
अब फिर गया कुछ हो गया.
Madam, you are not audible.
Ginni, your connection is actually, you are not audible, Ginni.
डॉक्टर गिनी, आप म्यूटेड तो नहीं है, लेकिन कुछ कनेक्शन इशू है, प्रॉबेबली आपकी आवाज नहीं आ रही है.
Dr. Ginni, we can't hear you.
In the meantime, I think Dr. Jyoti, आप
Anu, you can introduce. Anu?
Yeah.
Is that better
So
now?
So
Is that better?
Yes.
Yes, now we can hear.
Okay. Thank you everybody for including us Punjab people also in this beautiful seminar on endometriosis, which is a burning topic with daily OPD of such a big load of daily young patients, younger and younger patients coming. So we welcome Dr. Asha Rao, who is MD, DGO and Fellow of the Indian College of OBGY. She is an international faculty amongst us. Director, Rao Hospital and Care, Coimbatore, Director for Postdoctoral Fellowship Program in Reproductive Medicine and endogynecologist affiliated to TN Dr. MGR University. She's a chairperson of the Endometriosis Committee of FOGSI till 20 to 2023 and past president Coimbatore OB/GYN Society. And so many conferences have been organized by her. She has publications on adenomyosis and a chapter on fertility enhancing surgery. Also is a co-editor of the book on endometriosis and clinical management. So she has other achievements too. And we welcome her, and she will throw insight on the medical management of endometriosis and what is new, because the disease load is increasing day by day, and any more knowledge and information is always welcome. Over to you, Dr. Asha.
Thank you, Ginni, for those kind words. And at the outset, let me congratulate Jyoti Banglowala for having organized such a beautiful symposium. And I'm very glad to see here very many of my friends, starting from Anu Chawla, Meenu Vaish, then Anupam Chutela, Archana Singh, so many of you beautiful young ladies. It's lovely meeting all of you on this day of Gudi Padwa or Yugadi. And as mentioned already, endometriosis is a burning topic of the day because, shall I just share my screen? Yeah.
Yes, ma'am.
More than 200 million women are affected by endometriosis world over. And of these, we have almost 30 million women in India. And it causes severe pain and pelvic pain and infertility. And younger the age at onset, more severe is the disease. And in spite of a research of more than 200 years, we still have a lot of difficulties, diagnosis, dilemmas, and disputes in management. Should we treat it medically? Should we treat it surgically? We always have a debate. That's how I think Jyoti has chosen this topic of medical management, because diagnosis of endometriosis started as a surgical diagnosis, because those days when we were students, say 1975, 1976, there was no ultrasound, there was no laparoscopy. So anybody who had pain and continued to have pain, the surgeons would be, okay, let's make a small opening and see. That's how the diagnosis started. And later came the laparoscopy. And we started laparoscopy way back in 1976. And that's how laparoscopy was the mainstay for diagnosis of laparoscopy for diagnosis and laparotomy for management. This is how it was. And then around 1982, we got the ultrasound. And since then, I think we have never looked back. Imaging has become the mainstay of diagnosis today. And all of us know about the pathogenesis of endometriosis, the increased estrogen sensitivity, progesterone resistance, increased inflammation, so many changes at molecular level, increased cell proliferation, fibrosis, neuroangiogenesis, invasion, and all this together causing pain and infertility, which are the hallmarks of the disease. And there are 7 Ds: difficulty in conception, dysmenorrhea, dysuria, dyschezia. And the most important, the 8th D is atrocious delay in diagnosis. It may take something like 4 to 8 years for diagnosing a disease. Is it because we try, tell our young children right from beginning, you are a girl, you are a woman, you have to bear pain. You should not grumble about it. And tells her mother says, no, you learn to cope up with it. And then you go to the family doctor who will look at your tongue, who will look at your eyes and say, you are not anemic, you have no problem. Beta, ye sab acha theek ho jayega, shaadi ho jayegi to acha ho jayega. And so that's how we pacify our girls. And by the time we have a proper diagnosis, it's almost 7 to 8 years, and many of them are in stage 3 to 4 disease. Once again, it is because there is a fear of doing a diagnosis on them by laparoscopy, because laparoscopy used to be the gold standard for diagnosis. But today, more and more, we have learned to dissociate from this and do a non-invasive diagnosis. So talking about the management again, the management used to be surgery for diagnosis, surgery for management, surgical, medical, and today we also have ART, which is part and parcel of the treatment for infertility. And today we really have a strong rethinking on endometriosis, because endometriosis can be suspected without surgical exploration. You listen to the patient carefully. Many of us do not listen. We just say, oh, pain during periods, okay, do a scan, come back. And maybe your junior doctor will be talking. They may not even elicit proper history. If you do a good history taking, you can suspect the disease in about 80% of girls. So it can be suspected without surgical exploration. And today, according to ESHRE, medical treatment can be prescribed without histological confirmation. So diagnosis of endometriosis should no longer be considered as synonym of immediate surgery. And once you diagnose, you need not be rushing for surgery to clear the disease. We have wonderful medication which can help women to control the disease. So diagnose it non-surgically by good history taking and imaging, and do not rush for surgery for diagnosis, because laparoscopy is no longer the diagnostic gold standard. And it's recommended only in patients with negative imaging results or where empirical treatment was unsuccessful. And this is according to the ESHRE Endometriosis Guidelines 2022. The goals of management in endometriosis are: the disease is viewed as a chronic inflammatory disease, requires a lifelong management plan, and the goal is to maximize the usage of medical treatment and avoid repeated surgical procedure in these young women who are suffering already with pain and infertility, and to reduce the delay in diagnosis, and once again, reduce the effects of unnecessary surgeries. So definitely one should do more and more of medical management, because the disease is a lifelong disease. Just by removing a tip of the iceberg, removing a piece of endometrioma or adenomyosis is not going to cure the disease. So it is medical management which is required more often, because it is called an endometriosis life. By Professor Chaperon calls it an endometriosis life. Once it starts in a woman, it never seems to leave her. So we have to treat her lifelong, and the mainstay would be medical management. And how does medical management act? The disease is caused by estrogen dominance and progesterone resistance. So suppress the estrogens, reduce the retrograde spill, overcome progesterone resistance, anti-inflammatory action, aromatase inhibition, anti-angiogenic and immune modulation. All these properties are incorporated into medical management. And how we treat depends on the age of the woman, her symptoms, requirements for fertility, severity of the disease, pre-treatment, cause of the disease, and side effects. And more than anything, it is the evidence that is very important. So the main problems are pain and infertility. So talking about medical management, if infertility is the chief complaint of the person, then giving a medical management to suppress a disease is totally out of question. So medical management becomes an important mode of managing pain. So coming to the pain management, the pain is mild or moderate. You have to consider empiric treatment with OCP or progestins. And if there is no relief in pain, or the disease is moderate to severe and there is no response to medication, that is the time that you can go in for laparoscopy. Not just for diagnosis, you do a therapeutic laparoscopy. So do a laparoscopy excision and evaluate the lesions and release the adhesions as and when required. And earlier we used to give up medical management for 3 to 4 months after surgery. This is not enough because the chance of recurrence are very high. So immediate post-surgical therapy with the Dynogest, OCP or GnRH analogs has to be given for a couple of years, depending on the stage of the disease and depending on her fertility requirement. If it's a young girl who doesn't want to get pregnant for 7-8 years, then you should definitely keep her under observation and you have to give a long-term medical management. Because if you do not do that, you can have a recurrence very quickly. So the indications for medical management are managing pain if fertility is not desired, adolescent endometriosis, where therapy, and recurrent endometriosis, prevent and treat, post-operative therapy. Today, more and more, we're not giving pre-operative therapy, pre-ART suppression, and extragenital endometriosis. These are the strong indications for medical management. And the currently available medications are NSAID, of course, for pain relief. Then you have the OCP, Dynogest, aromatase inhibitors, GnRH analogs, and agonists. Danazol was our favorite of the yesteryears, but it lost popularity because of the very strong androgenic side effects. So the first line of therapy is combined oral contraceptives or progestins. Today, both are considered as the first line of therapy by ESHRE. With COC, many people have a vast experience. But today, more and more, Dynogest is taking upper hand. And second line of therapy is either GnRH analog or surgery, and long-term medical management with LNG-IUS. And each of these medications have their own side effects. Oral contraceptives act by inhibition of HPO axis, pseudo-pregnancy regime, but they can also cause a lot of headache, nausea, hypertension. And when we use OCP for a long time, one of the arguments by these scientists like Chaperon or Vassalini is that there is a apparent pain reduction, but there can be continuation of the endometriosis and maybe a higher incidence of deep infiltrative endometriosis. This is one reason that more and more progestins are gaining upper hand. Progestins cause desensitization and atrophy of the endometrial tissue, immune modulation effect, inhibition of matrix metalloproteinases. They have anti-inflammatory action and also anti-angiogenic effect. And progestins can be, especially Dynogest, can be considered for use as first-line empirical therapy. According to the ESHRE 2022, Dynogest is the only progestin that combines the properties of both 19-norprogestins and progesterone derivatives. It has got both central and local effects. It causes inhibition of gonadotropin secretion and also suppresses the ovarian function. It can cause anovulation at a 2 milligram dose, but it's not really labeled as a contraceptive. It has anti-proliferative, anti-inflammatory, and anti-angiogenic effects. It has action on both utopic endometrium and ectopic endometrium, very good for pain relief. It also causes reduction in bleeding, but sometimes spotting can be a nuisance problem of Dynogest. And talking about the size of the lesions, if you use it for 20 to 24 weeks, then can be very good reduction in the size of the lesion in more than 80% of patients. but be patient and do not stop. Most of us have a habit of looking at 8 weeks to 12 weeks and say, no, there is not much reduction. But be patient and use it long term. You will definitely achieve a reduction in the size of the lesion. And if you combine with estrogen, there are some preparations which are coming with estrogen. The cost is less. That's attractive to many practitioners. But a reduction in the size of the lesion doesn't seem to be obvious when you use a combination of estrogen with Dynogest. And when you use Dynogest, it has progesterogenic activity, no glucocorticoid activity. It has no androgenic activity, and it has anti-androgenic activity. So it scores over all the other medication, does not have mineralocorticoid activity, so no water retention. And another very good point is that it maintains the estradiol levels in the serum between 30 to 60 picogram per ml. So it decreases the size of the lesion, but does not cause significant bone loss. That's very, very important, because many times we may need to use this long term, because recurrence of endometriosis after surgery can happen in endometriomas or in DIE. And without medication, in 2 years, there can be recurrence of 21%. And in 5 years, there can be recurrence up to 50%. If you use OCP, less than 1 year, the recurrence can be 49%. And when you use it for more than 1 year, still you can have a recurrence in about 22%. But if you use Dynogest over 5 years, the chance of recurrence seems to be hardly about 2 to 5%, which is very important. And you can also use Dynogest after the initial GnRH analog therapy. If the pain is severe, initially you can use GnRH analog, and after about 8 to 12 weeks, you can follow it up with Dynogest, and you can strike a balance between bone loss of BMD and also the cost of therapy. And this is one of my patients. She was a doctor, 24 years, unmarried. She had just finished her NEET counseling and wait for her post-graduation seat. And she came with severe dysmenorrhea. And she said she always had dysmenorrhea, but it had really become bad in the last 4 to 6 months. And on ultrasound, she had bilateral chocolate cyst. One was 10 into 6.7 centimeter, and other one was 2 into 3 centimeters with the right hematosalpinx. She was not relieved by antispasmodic, dyschezia, and the size of the lesion was pretty big, and her CA-125 was 674. It seemed to be an aggressive lesion. And when we told them about the fertility, loss of fertility sometimes with surgery, the mother said, no, I'll get her married. Let her get pregnant, let her get married, other ovaries, okay. Do not do surgery on my daughter. So initially we gave her a suppression with GnRH analog, but over 6 weeks, there was not much relief. So we went in for surgery and removed the endometrioma. And she also had a 5 centimeter fibroid, which is subserous, but anyway, we managed to remove it also. And this is one person, a young girl, unmarried girl, and she's a doctor who is going for post-graduation. I'm very sure that she may not like to have children for 4 or 5 years or longer. So this kind of person definitely needs a long-term medical suppression. So this girl is now put on Dynogest. It's about 1 year. She has done very well. She recently had an ultrasound, very happy. And she's very busy with her post-graduation. So we have asked her to come back once a year for surveillance. And we told her to take Dynogest at least for 5 years. But keep in touch and tell us whenever she gets married, wants to get married, we can always review her therapy. But otherwise, for 5 years, she can definitely take the Dynogest therapy. And in the contrast, this is another young lady who came to us with severe dysmenorrhea, dyschezia, dyspareunia. She is married for 1 year and she had very severe pain. She said it was very difficult for her to have sex. Male factor was normal, so we obviously had to go in for laparoscopy. And this large chocolate cyst was removed. And we saw that the tubes were supple and tubes were patent. And this lady, definitely, we should not suppress. There is no need for suppression. Do her endometriose fertility index and see what are the chances of getting pregnant. So a woman she had adhesions in the pelvis, but tubes were patent and free. So this lady, within 2 months, she had a natural conception. We had told her that after 2 months, we'll go for IUI. But in the meanwhile, she has conceived and she has had a non-vaginal delivery also. You can review this and see there were no adhesions around the fallopian tubes. and good candidate for conception. And coming back to Dynogest again, so give medical suppression in women who are not interested in pregnancy, but if the woman is interested in pregnancy, do not give her a post-operative suppression. This is the summary. And Dynogest can be safely offered to adolescents. It can also be used for a period of 5 years and beyond in girls more than 18 years. Immediate return of fertility, cost effective in comparison with GnRH analog. There is no reduction of BMD, maybe 1.2% the first year, which again seems to get corrected. No hot flashes and good relief of pain. And some of them may complain of a little breast discomfort. One of the nuisance problems seems to be menorrhagia, which can happen in about, or spotting, which can be there in about almost 60 to 70% of patients. So counseling these girls is very important. And according to the Visado study done in 18 centers of Europe over 7 years, between the age group of 12 to 18 years, they saw that it was very effective and safe for a period of 52 weeks. That's for 1 year. But later in the general population, there was a VIPOS study using Bisan. And once again, here, this was a study for 7 years. And they concluded that the side effect is very minimal and you can use it safely for a period of 7 years. Retroprogesterone like dydrogesterone have been used. It has immunomodulatory effect. It can be given a dosage of 10 milligram twice daily from day 5 to 25. No weight gain, no edema. It causes atrophy of the ectopic endometrium. And according to the proponents of this, they say that patients can conceive on dydrogesterone, but I do not have much experience with dydrogesterone. Date 5 to 25 use dydrogesterone, allow them to use the fertile period, and pregnancies have been reported. LNG-IUS is our favorite in women who do not want fertility. Continuous exposure leads to atrophy of the endometrium, and 60% of them go into amenorrhea in about 6 months. Post-operative treatment with LNG-IUS reduces the recurrence of pain, and continuation rate is almost around 70%. We have more than 80 or 90 patients who have used it for 5 to 7 years. In fact, one of my patients, when I told her at the end of 6 years that it's time for you to remove the LNG-IUS and you can insert a new one, she just disappeared. She did not come back. She stopped coming. Then I saw her at the end of 14 years. And that 14th year, she started having a recurrence of symptoms. So I had put the Mirena at 34 years, and now she returned at 48 years. And now there was a recurrence of chocolate cyst and adenomyosis also. She underwent a laparoscopic hysterectomy. So she was very happy for about 10 to 12 years with the LNG-IUS. And LNG-IUS and GnRH can have a comparable effect, and the combination also works very well. Even in a slightly larger size uterus, you can give an initial GnRH analog. If the uterus is about 10 to 12 weeks size, we are always worried about the chance of expulsion. So I give a GnRH depot first, 11.25, and after about 8 weeks, I insert the LNG-IUS. So the expulsion chances are much less, are very good. You can also use depomedoxyprogesterone acetate. Etonorgestrel subdermal implants are available abroad, not yet in India, seem to be pretty effective. GnRH agonist is our favorite in the infertility clinics. It is a second line of management, FDA approved. You can use it post-surgery for prevention of pain, prevention of recurrence, but we do not advocate it for more than 6 months. It gives very effective regression of lesions, but reduction of bone density is a serious side effect. That's how we say that do not use it for more than 6 months. And it is wiser to use it along with norethistone acetate to prevent the bone loss of bone mineral density. So add-back therapy is always recommended. And if you're using it slightly longer, do a BMD every 2 years. But none of my patients, I think I have used it for more than 1 year. Whenever I use it long-term, I have used it with add-back therapy. So empiric use is allowed to avoid a diagnostic laparoscopy. And in youngsters, do not use empirically before 18 years because you may interfere with the bone growth. And ACOG endorses its use over 18 years. And you can always use initial GnRH followed by Dinoges. So you'll have a good combination of pain management. This is one of our patients who was married for 39 years, infertility of 15 years, adenomyomectomy at local hospital, recurrence within 1 year, no pregnancy. She had one failed IVF elsewhere. So she's failed adenomyomectomy and failed IVF elsewhere. And she came with a 6 centimeter adenomyosis in the posterior wall. And this was in year 2006, 16 years back. So this lady, we gave 2 doses of long GnRH agonist suppression. That's for 6 months, which caused a decrease in size of adenomyosis. And then she had embryo transfer with egg donation because she was already 39 and exhausted her ovaries. And 2 embryos became triplets, but fortunately 1 vanished. And she also had a low-lying placenta, but she had a good outcome, LSAS at 36 weeks with good-sized twins in March 2007. So medical management helped us to give a pregnancy to this woman who already had a failed adenomyomectomy elsewhere. Danazol was very popular. And today there is trial going on in the European countries with the intrauterine device and also vaginal danazol. So when you use it vaginally, the androgenic side effects are almost nil and seems to be useful for control of pain, also useful in DIE. Aromatase inhibitors. Aromatase inhibitors can be used as a second-line drug for managing endometriosis. It has central, peripheral, and local action and can cause immediate reduction of estrogens because GnRH can have a flare effect initially and then suppression after a couple of weeks. So if you use aromatase with GnRH, again, there is a beneficial effect. There is no hot flushes. So you can use it along with the progestogen or also with GnRH analog. But it causes profound hypoestrogenism, loss of bone mineral density, but very good for pain relief. Letrozole 2.5 milligram along with northistrone can be given for 6 months. Anastrozole 1 milligram along with progesterones can also be given for 4 to 6 months. Very good for relief of pain. And this is one of our patients with large adenomyosis. She came in the COVID year. This was 344 cc uterine volume, something like a 12-week size uterus. And you can see she has got a 7 into 4.4 centimeter size adenomyosis. And her AMH was 1.26, low AMH. And this lady, many doctors would say adenomyomectomy, but we went in for suppression for 7 months. The first step what we did was we did an antagonist protocol and vitrified the embryos. And then we suppressed her from February to September with 2 doses of 11.25 and again a 3rd dose along with letrozole 2.5 milligram twice daily and then northistrone acetate 5 milligram. So with this combination, the uterine size came down from 344 cc to 204 cc. And that stage she underwent frozen embryo transfer and she conceived. You can see this uterus with the 12 weeks pregnancy and the adenomyosis here. So, which is quite significant. We were worried about preterm delivery, but did not happen. Aromatase suppression was very good. She had a 37 weeks LSCS and a live baby, which is about 2 years old now. The newer drugs are elagolix, the oral antagonist, FDA approved. I would say grapes are sour because it's not available in India. Cost is quite expensive. Recently, when we went to the SUD conference, we heard a lot about it. But once again, until it comes in India, it is not available to us. You can also use tamoxifen, riloxafen, which are the SERMs. You can use esopristol, ulipristal. You can use mifepristone. Statins are being tried. Statins have anti-inflammatory action, also immunomodulatory properties, but we are a bit worried about the teratogenic side effects, but they are under study. Angiogenic inhibitors like cabergoline, dopamine agonists are being tried for pain relief in DIE. It has anti-angiogenic and neurogenic properties. So today, as we stand here today, we have a rethinking on endometriosis. These are my concluding slides. This is from Chapron et al. He says in endometriosis life of the woman, do a non-surgical diagnosis followed by long-term medical treatment. So no surgical diagnosis, no surgery immediately. Non-surgical diagnosis by imaging and her symptoms, long-term medical management. And when she needs a pregnancy, go in for either try IUI or allow her to get pregnant or ART. And after childbirth, again go in for long-term medical management, avoiding surgery as much as possible. There can be another category, which is non-surgical diagnosis followed by long-term medical management. And sometimes, if necessary, you may do a unique surgery once in a life, which gives her the best results. And if there is no result, go in for ART. And after ART, again, long-term medical management. And only if needed, at the end of her reproductive career, if she has problems, do a definitive surgery like hysterectomy, whatever is required. So avoid surgery as much as possible in these young women. So to conclude, endometriosis is a chronic inflammatory disease which requires supportive and continuous medical therapy. The usage of medical management can have side effects and interferes with fertility. So use it with a good rationale. Medical management should replace surgical management. And we'll have many more RCT to say which is the best medical management, which will give you a long-term suppression with minimal side effects. Thank you all.
Thank you. Thank you very much, madam. It's a very nice elaborated talk with the case studies also. And I request Dr. Anu Chawla to just give her remarks. Anu, you are muted. Anu, you are muted.
Okay, okay. Can you hear me now? Yeah, can you hear me now?
Yes.
Perfect. So thank you so much, our very, very dear chairperson of Endometriosis Committee of FOXI, a very important pillar of FOXI for the last 3 years and very rightly extended for another 1 year. So for a long time, she has actually served us as the chairperson of a very important committee. Dr. Asha Rao has a tremendous journey, and I am very inspired personally by her energy at this age. Now, Dr. Jyoti Banglawala, you have actually really started a fantastic campaign. I didn't know about this, and I just understood how much of work and service are you doing for FOXI, and I really appreciate you for that. Coming to the Dr. Asha Rao's lecture, your lecture was really genuinely covering every important aspect, and one important take-home message that I would definitely want to emphasize is empathy. Like you said, that people think and the relatives think that the pain is in their minds. It is not in their minds, it is in their pelvis. So this is a very important point to sensitize, along with the stress on the conservative management that you have created through your lecture. I want to thank Dr. Anupama, Dr. Reena, Dr. Gini, Dr. Archana, Dr. Jyotsna, Dr. Sonam, Dr. Meenu, Dr. Chitrakala. I can see everybody here. Dr. Anushri, Dr. Sonam, and I'm sorry if I'm not seeing anybody here. So delighted to be with everybody. Thank you.
Thank you, Anu, and thank you.
Thank you,
Asha,
Jyoti,
madam,
for this wonderful opportunity to talk to so many of you.
Yes, thank you, madam. And actually, you said it rightly. Ki every time when we say to the young girls ki it will vanish after your marriage, it is not right. It affects their studies, it affects their day-to-day life, and we have to actually sensitize all the parents, all the girls about the endometriosis. And thank you, madam. Thank you for being.
The motto of our endometriosis committee, the logo is think endometriosis, fight endometriosis.
Yes, yes,
and this month being the awareness month, where you would have seen a lot of flyers bombarding you all the time about Endo March, which is a program for increasing the awareness. And we also have a walkathon on Sunday. And I request all of you, we still have either 10 days in March, try and do awareness activities at whichever level you can.
Yes, madam. Yes,
thank
madam.
you.
Ma'am, one point before we move on. Just one question.
I saw the wonderful slides. Your pictures.
Asha Rao, one question for you.
Dr.
Does FOXI still endorse using LNG IUS for nulliparas? Does FOXI still endorse using LNG IUS for nulliparas and with endometriosis?
Yes, we would.
Yes, that is what I just wanted you to make home for everybody.
मेरा भी एक छोटा सा क्वेश्चन था डॉक्टर आशा Let me tell you, Dr. Asha is one person who has always inspired me. और मैडम का जो ट्रीटमेंट होता है, somehow I felt कि वही मोडालिटी ओवर द इयर्स मैंने भी डेवलप की हुई है, तो इसलिए मुझे और ज्यादा ऑ में रहती हूँ मैं डॉक्टर आशा के. एंड आशा मैम, आपसे मुझे एक चीज बस पूछनी है जो बहुत ही प्रैक्टिकल और छोटी सी चीज है. दैट आई डोंट नो इफ यू आर अंडरस्टैंडिंग माय हिंदी.
Yes, of
Madam
course.
is so good
I
in
do
Hindi.
understand. My father is a Hindi professor.
Okay.
Great.
The other day I was talking to you and I went on very rapidly in Hindi and ma'am said, "What are you saying? Just slow down, slow down." So I thought, maybe. So ma'am, I just had this query that Dynogest, when you give, as a medical management, you said that to other girl after surgery, you gave her Dynogest for long term. So is it continuous or sometimes you give a break in Dynogest?
We give it continuous.
For 5 years, you can give it?
No, I have had no experience of using it for 5 years. To be honest, I think I have used it more often for about 1.5 years, because most of my patients are infertile patients. So there is no question of using. And one of occasional young girl that comes who is not married and wants to wait for another 4-5 years. I think even OCP earlier have used for about 2 years.
When we are giving it not to an infertile patient, other patients, when we are giving Dynogest, I just have this in my mind. How long can I give it? Should I give a break in between and then restart? This is a very common query which comes in my mind and people do ask me. So I was wanting to have
giving a break does not really help. So you can use it continuous, but patients themselves have the habit of stopping it either because of financial reasons or because they feel, I do not want a tablet for a long time. So they tend to stop it.
And do you have any experience with dydrogesterone?
No. Somehow, I do not know. I do not like to use it. I do not like the idea of giving progesterone from day 5 to day 25.
मेरे को try करना है किसी patient में. मैं भी यही सोच रही थी कि आप.
But Dr. Trivedi is a big supporter of dydrogesterone.
Yeah, but I'm still not convinced whether the patient would get conceived on a progesterone, but still I will try it sometime. Yeah.
Yeah, I think it's time all of us try it.
I can.
Yes.
Yeah. So about the use of Dynogest long term, Dr. Ramani Devi, who is a very highly respected another person in endometriosis, I have been talking about her for one of the trials that I was involved in, and she actually has a lot of experience to use it for a lot of number of years, and Dr. Nandita is the second person. So these two have used Dynogest in patients for over 4 to 5 years very comfortably without any break. I just wanted to tell you that what is happening around us. And also, I want to just highlight one more point, which is that the new guidelines, as Dr. Asha Rao's, I'm just re-emphasizing, she's also already mentioned in her lecture, that in cases of subfertile patients, we as an IVF practitioner myself, I also used to do agonist monthly, but the new guideline has actually emphasized that we should not promote this as a regular protocol. What I do is I do color Doppler, and if generally these patients also have some element of adenomyosis, and if it is a very highly vascular adenomyosis, then I still give one. I haven't totally changed my practice, I have to confess, but I still give one agonist dose, but not anymore for 3 monthly like we used to give. At the same time, it's important to take out eggs before we start calming the inflammation in the pelvis by giving a lot of agonist doses. So especially because most of these patients will be poor responders. Yeah, that was my input.
Yeah, that's true. I have an experience giving the patient for 2 years. In one of my patients, she had a severe endometriosis, and her husband was in Dubai, and she was planning to conceive after 3 years. And the endometriosis part is totally disappeared. Now I have stopped. And after that, 3 months after that, we did all the tests, her infertility profile, and they are quite normal. And now she's ready to go for IVF. So this much is my experience also.
Yes, Madam,
but Dr. Asha has already told that continuous. I think as Dr. Anu is telling and Dr. Asha is telling, it has to be given continuously. Only then we can get better results and we can comply on medicine.
Yes, madam, we can
And
give
what's
it
your opinion?
continuously for 5-6 years. Many patients are taking, but when the
Yeah.
patients are apprehensive, we can give them 1 month break actually. Just
Yeah,
to be
but
mentally
whenever I
relaxed.
require, the main reason I do long term is whenever they require a long term, I give them more of intrauterine device.
Yes, ma'am.
That is the reason.
Yes.
And they are very comfortable with the intrauterine device. And whoever is not willing for intrauterine device, you can suggest them oral, Dynagist.
Yes, yes, ma'am.
And
One-
last question.
Asha?
After the Vizardo study, we all started using Dynagest in the Punjab area for the adolescents. What are you giving for troublesome breakthrough? Adolescents do not like troublesome breakthrough. It goes on and on for many days. It interferes with their sports, and many adolescents are sexually active also. So, what do you give for breakthrough on Dynagest?
Sometimes you just step up the dose temporarily for a month or so, they are all right, number one. Sometimes you give a additional regesterone, high dose, they are all right. And I think very rarely we have given added estrogen.
Yes, that's what I wanted to know.
Not
Sometimes we
frequently.
need-
No, that's the last one I will do.
Because it's atrophy. So, atrophy needs a little growth over there. No?
Okay.
What brand of GnRH agonist 3 months, the 11.25, what brand do you use? Whenever I have used, my patients have escaped. And the 1 monthly ones are the ones which are okay in quality, and this 3 monthly ones are usually not so good a quality. So
I'm very happy with the leuprolide acetate.
okay, that's the Bharat people.
I use, we're not supposed to mention the names, but I'm using Sanpharma.
Okay, नहीं मैं मुझे पूछना है क्योंकि मुझे practically use करना है.
Pretty good.
ठीक है, thank you.
Okay, thank you, madam. Thank you, Asha, madam. And
Thank
you. Thank you for what you.
Thanks for
Now-
giving
And
time
I
for the
forgot
lovely
to mention,
Thank you.
I forgot to say hello to Dr. Nivedita. Hi, Dr.
Nivedita is
Nivedita.
traveling. I think Nivedita is traveling, I think.
Yeah, yeah.
Yes.
She's
Dr.
covering her
Nivedita,
face. I
good
couldn't
evening. She's
understand.
part of Safe Motherhood Committee also with us.
Yes.
Leaders, one of the leaders of the Safe Committee.
So wish you all the best, Jyoti.
Yes, thank you, ma'am. Thank you, ma'am. Thank you very much, ma'am. And now we are moving to our another session. And most of the time we do generally one talk and one patient or non-patient interactions or doctor's interaction. But being Endometriosis Awareness Month, we took this panel discussion on clinical dilemmas in endometriosis management. It is case-based. And today's our moderator are Dr. Sonam Jain, and our expert is Dr. Meenu Vash. Chitrakala, please. Dr. Sonam Jain is MBBS DNB, and she is a member Foxy, Manyata Foxy, member Safe Motherhood Committee, and her area of interest is high-risk pregnancy management, laparoscopy and hysteroscopy, diagnostic and therapeutic procedures, infertility management, and she has keen interest in medical management of ectopic pregnancies. Her achievements are Foxy Secretary in the Kashipur branch 2022 to 23. She is trainer of Manyata training program Foxy. She presented multiple papers in national and state conferences and panelist in various conferences. And she conducted various school, adolescent health and menstrual hygiene programs and conducted cervical cancer screening program through pap smear via Foxy. And she's got the Yuva Foxy Achiever Award. Welcome, Dr. Sonam Jain. Our expert today is Dr. Meenu Vash, madam. She is present president Uttarakhand Society of Obstetrics and Gynecology, and immediate past president Gynae of Society of Dehradun. Medical excellence, she has medical excellence award by Chief Minister of Uttarakhand in 2018 and got Best Doctor Award by UMA in 2008. And she was the organizing secretary at Dehradun
Jyoti, we should not waste time. We should go ahead.
Okay, okay, madam. Today our panelist, Suman, please just go through a small introduction of all the panelists. Sumanji, put the
Yes,
slide.
ma'am. Chitra?
Yes. Today our panelists are Dr. Archana Singh, madam. She is secretary Uttarakhand Obs Gynae Society. Dr. Nivedita Datta, madam. She is president Bokaro Obs Gynae Society. Dr. Anushri Rawal, madam. She is secretary Haldwani Obs Gynae Society. Dr. Reena Singhal, ma'am. She is director Single Nursing Home and Maternity Home. Dr. Anupama Futela, ma'am. She is founder president Rudrapur Obs Gynae Society. And Dr. Jyotsna Agarwal, madam. She is secretary Roorkee Obs Gynae Society. And today Sonam picked the cases of day-to-day practice point of view and very simple cases. And I hope all the non-viewer doctors also can get some take-home messages. Over to you, Sonam.
Thank you for the invitation in the panel.
And Josna, actually, it is the YouTube live and it will be put on the non-doctor domain also. So I asked Sonam to put general questions and general we have the general practitioner doctor also as a viewer.
Okay.
Over to you, Sonam.
Thank you, ma'am. I would like to thank Jyoti ma'am and Asha Rao ma'am for involving our Uttarakhand Society for this awareness program, ma'am. Without wasting our time, we have got all the experts and experts of all Asha Rao ma'am and Neelmash ma'am with us. I'll start my screen sharing. I have put cases of all age group and we'll just be dealing case by case. This is the first case. Here we have got an 18 years old girl which has come with the complaints of severe dysmenorrhea. Her cycles are regular, 3 to 4 days with a normal flow. Her ultrasound is showing us 4 centimeter endometrioma in the right ovary and a 5 centimeter endometrioma in the left ovary. Test findings are negative. Now I would like Dr. Anushri for taking up this case. Ma'am, how will you take the first line of treatment for her and how will you counsel this young girl, ma'am, as a parent will also be very anxious? Dr. Anushri?
Hello, can you hear me?
Yes, ma'am. Ma'am, you are audible, ma'am.
Hello.
Ma'am,
Thank you.
make the slides
Madam, can you full screen?
Thank you, Dr. Jyoti, for giving me this opportunity.
Hello. Slideshow को on कर लो.
Ma'am, वही कर रही हूँ.
Perfect.
Should I continue?
Yes, ma'am. आप continue करिए.
Yeah. Though as like she's an adolescent girl, and the first thing that we have to tell her that she has a progressive disease, and we may eventually she may develop severe symptoms or infertility, and eventually she might have to undergo surgery. But according to me, the first line of management that we should give here should be either a low dose combined OCP or a Dynogest, as ma'am has already told us. And we can start by giving it for a period of 6 months, that is 24 weeks, and we can see the changes or the results. I've also read somewhere that the change of the cyst size might take a little bit longer. However, the symptoms will abate. So we should wait and watch in this case. And many surgeons also say that even in adolescence, you can offer her laparoscopy. However, it is not the first line of management. You should first try medical therapy, and if it fails, then we should try a laparoscopy, a therapeutic laparoscopy.
Thank you, ma'am.
And we can also tell her that she will have a chronic phase, and there might be recurrence, and in future also she might require laparoscopy for conceiving. So all this we have to tell her, and she should be prepared for the outcomes.
Thank you, ma'am.
Can I add something? Is it allowed?
Yes, ma'am.
Can I add something?
Yes, ma'am. Yes, ma'am.
Yes, of course, ma'am.
I just added one input that traditionally we've been using low dose contraceptive tablets in these girls, and the new message which I wanted to give to all fellow gynecologists is that let that not be our first choice. Though it is easiest to use, but it is better to use a Dynogest. If there is some other additional factor, like the girl is wanting contraception as well, then maybe we can consider. But otherwise, Dynogest, even if it's costlier, that should be our first modality, because it is said that COC somehow later on can cause more chances of deeply infiltrating endometriosis.
Yes, true, ma'am. Actually, the recommendations of the ICOG panel and even American societies and even RCOG still sticking to COC. I think they're going to change that. However, everybody, it is like, I think now we all accept that Dynogest is the first line. We mostly give that only. So yes, ma'am. True. I agree.
We agree with Anupama here, because the
Yes.
Dynogest will again flare up the endometriosis, and later on in she is only 16 years old girl, Sonam.
Yes, ma'am. 18 years old, ma'am.
18 years old girl. So she has got long life to live, and she has got all the parameters to cover pregnancy, adolescent, and reproductive age, and everything. So OCP in the long run will be very harmful.
Yes,
And
yes, true, ma'am, true.
there is evidence that it will cause deep infiltrating endometriosis.
And that too, in endometriosis, they say that you give a continuous OCP. Then only it is going to be effective. So it's better to give continuous Dynogest.
Moving forward, I would request Reena Singhal ma'am to tell us what shall be the indications of the surgical management in this patient if we have to go through, and what shall be the post-op management, ma'am. Do we add any adjuvant drugs we add on, ma'am, after surgery?
Hello everyone. In a young girl of 18 years, as she's a young girl of 18 years, and she's having bilateral endometriomas, and size of one is 1 centimeter and another is 5 centimeter. So firstly, I will counsel her because counseling is very much important, as it is a progressive disease and it will destroy the ovarian follicles. So I will counsel her about the disease and its nature and the fertility issues. So, but if the medical treatment fails, then I will suggest for the laparoscopy, which is a gold standard for this, and it is diagnostic as well as therapeutic. And it may be possible that there are some other peritoneal implants of endometriosis, which can be diagnosed by laparoscopy, and I advise her for laparoscopic cystectomy after.
Like ma'am has rightly said, ma'am, if there's no decrease in the size of the endometrioma, or there's no relief in the symptoms of the patient,
Yes,
we can ask her for the surgery. And if the patient is requiring fertility, if such much big size of endometrioma, we can go for a surgery, because they may have a risk of rupture.
If the symptoms are not relieved, and of course there is a risk of rupture of endometrioma
in the patients which require surgery for
pelvic abscess, and then it is necessary to do the laparoscopic cystectomy of the patient. And after the surgery, I will advise a regular follow-up, because there is a recurrence of the disease, and I will advise for Dynogest for 6 months, or OCs we can give, but it is, if there is Dynogest, I will prefer to give Dynogest for I think we should give it 4 or 5 years, and we should look by ultrasonography and other things. Pain is relieved, or the size of the endometrioma is not increasing, or we can see the.
Thank you, ma'am. Now moving forward, now we're coming to this patient. She's a 32 years old female, married for 4 years. She's keen to conceive. Her male factors are normal. Her cycles are regular and associated with pain. The rest of the findings are normal. Her ultrasound has got a 3 centimeter endometrioma in the left ovary. Can I have Niveta ma'am, have you joined us?
Yes, Sonam. Good afternoon.
Good afternoon, ma'am. Ma'am, would you like to take up with this case?
Good afternoon. Yeah, let's a 32-year-old wanting to conceive, and I assume other factors are normal.
Other factors are normal, ma'am.
Which it's we're only concerned about the endometriosis aspect of infertility. So in this, the first take-home first important message is that there is no requirement for immediate surgeries. So the important thing to do in this case initially is controlled ovarian stimulation with intrauterine insemination. You can try that, and most of them conceive with this. If they do not conceive with this, if you feel that okay, she's not conceiving with this, then you consider the other. You go ahead with the further management of infertility along the same lines. Do not suppress ovulation. because the moment you suppress ovulation and you suppress or you try to suppress the endometriosis, then you are decreasing her chances of infertility initially. Then and if there is a later requirement of artificial reproductive technology, ART, so then we will think of ovum pickup for these cases with initial in a routine protocol of IVF, like initial suppression and then stimulation. So that is the way you go with it. Now, just in case a laparoscopy is done and a laparoscopy is needed, and you feel that you have to, there are some complications and you need to go in for the cyst removal, which has been mentioned before. Then before you go in for all that, please do an AMH to see what is her AMH before the surgery, because the moment the surgery is done, the AMH will fall. So that should be done in comparison. That should be one baseline thing which should be done before you even contemplate cystectomy for any complications which can occur of the cyst, which has already been mentioned by Sonam before. I think that is what you want to know. Anything else you wanted to know?
Thank you, ma'am. Allow for the same case, ma'am, for this infertility, because I think endometriomas has been complicating the doctors also for all the patients who want to conceive. Ma'am, so the same patient, ma'am, if she turns her back to you after having done the endometrioma removal done at some outside place, and again she is keen to conceive, ma'am, shall we go for the, how shall we proceed further, ma'am? I would like Anupma ma'am to answer this question. She has a keen interest in infertility.
Thank you so much, Sonam, for that question. And thank you, Dr. Jyoti, for having me around. I'm very happy to have Dr. Asha also in the same session, who's been my god for endometriosis. She was the one who took me into endometriosis committee 3 years ago. And since then, I already had an interest in endometriosis. And let me tell you, wherever I am going to deliver any talk or something, if at all possible, I keep sensitizing my fellow gynecologists about endometriosis. And let me reiterate here that we always, most of us, like myself, earlier, when I didn't have this ultrasound machine, we underdiagnose endometriosis. So one very important message which I really want to pass on to all the gynecologists here is that we tend to underdiagnose endometriosis, and we should have very, very high index of suspicion for endometriosis. And there are a few points which I wanted you to all to understand is that what are those situations in which you should have high index of suspicion. Sometimes you will not really get an endometrioma, like you're not lucky as this patient, you get a history of 3 centimeter endometrioma on ultrasound. Sometimes you will get just a history of heavy periods, continuous dysmenorrhea. There are patients who are having early menarche and heavy losses. If you really go into that history, sometimes you will also get a history of neonatal bleed, that which is blood, which is called the childhood bleeding. So that is also one of the high risk of endometriosis. Of course, family history, anything, which is giving a high estrogen content in her body, that will make her more prone for endometriosis, as well as for fibroids, as well as for adenomyosis. So mostly, as the endometriosis advances, it is a hand-in-glove disease with adenomyosis. So whenever you are getting an endometriosis patient, you should also suspect that she might be having adenomyosis along with it. So we have to treat all in toto. Now, endometriosis in this patient who's already had a 3 centimeter, and I don't know why her surgery was done. It should not be done at 3 centimeter. But anyways, the 3 centimeter thing has been operated. And unfortunately, her AMH must have dropped a little bit. So if she had come to me without a surgery, the first and the foremost thing, if she would have been an unmarried girl, I would have asked her relatives to get her married as soon as possible, along with the medical management. Now, if we cannot do that, the marriage is not going to happen soon. At least medical management has to continue. And the previous case was a similar one. So apart from giving that long-term thing, there is one additional thing which after surgery should be done is the adding of GnRH agonist and LNG IUS. That is very, very easy to give, and you do not have to take it for long. Mostly patients would stop taking it and then will land up in problems later on. So at that stage only, LNG IUS should be given when the patient is still not ready to get married or not ready to conceive. But now we are lucky, and this patient is already married and she has already had her surgery done. So there cannot be a better time that she should conceive. Now, if she's trying for conception, I will only wait for 1 or 2 months. That is my maximum. I will not waste even 1 day giving her GnRH agonist or the treatment as has traditionally been taught to us in yesteryears, COCs de do patient ko. I will never waste a single day giving her COCs, because these patients, if we tend to give them COCs, we are losing the benefit of the surgery. So once we have done a surgery, the next 6 months are the best time for her to conceive. So, and pregnancy is the best treatment for her, because the decedulization which will happen in the pregnancy, that is the best treatment for any leftover endometriotic spots. So by hook or by crook, I'll try to make her pregnant. So first month, I will give her a trial of IUI, and no simple IUI. I will straight away try everything in my hand. I will give her gonadotrophins, because there are more chances of luteinized unruptured follicle in these patients. So I will not even just be on letrozole or something simple. I will straight away add her on stimulation, gonadotrophins also. I will trigger her also. I will give her IUI also. And if she would not get pregnant in a month or 2, I will straight away go for controlled ovarian stimulation followed by IVF.
Thank you, ma'am.
Very well spoken, very well. You have did the detailing of this case. And here I also agree, we need not to do the surgery. And since it is only 3 centimeters, we could have tried directly IUI. And we can give, if she is not able to conceive, there is other reason, there is a pain, there is anything, there is adhesions, and tubes are blocked. We are seeing by HSG tubes are blocked. Only then we should go for surgery. Otherwise, no need for 3 centimeters endometrioma. We need not to go for surgery. We can directly treat her by IUI, and this particular patient will be can be treated by first line management of IRT. Even with IUI, there are 60% chances of conception in these patients in endometriosis 1 and 2 group.
IVF में अगर during oocyte retrieval अगर endometrioma बीच में आ रहा है, that is the only indication of surgery in this patient. Otherwise, no other indication.
In fact, here can I just even in this case, like that's what our previous concept was, that even I had the same concept that if the endometrioma is in the passage of oocyte retrieval, then we need to remove the endometrioma. But I was just in another webinar on endometriosis, and they say that no, even now you can manipulate, and if you have to go through a chocolate cyst, you can go clean cut through the chocolate cyst and get do the retrieval, that's equally effective. You do not need to remove the endometriomas. So very, 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 I think key take-home message is that endometriomas below 3 centimeters need not be handled surgically.
Thank you, ma'am.
Anyhow,
I think
at one point of time, I used to do a lot of sclerotherapy, after doing the oocyte retrieval, I used to aspirate them, put alcohol over there. But over the time, I've learned that, still the chances of abscess is there. So we should try not to touch it at all if possible. Endometriomas are not to be touched during the oocyte retrieval. And
ma'am, would you like to do a tubal patency in this case before going for IUI?
I would not waste my time doing tubal patency in this patient.
See, usually endometriosis is not associated. Yes. I mean, sorry, is not associated with tubal pathologies. It is a peritoneal pathology. It is mainly peritoneal pathology, and then of course hormonal dysfunction. But it is tubal pathology.
But then subsequent adhesions because of endometriosis.
But we have to work up completely for infertility also.
और अगर हमें नहीं भी पता है ट्यूबल स्टेटस, स्टिल आई विल नॉट रियली वेस्ट एनी टाइम डूइंग HSG, बिकॉज समहाउ रिट्रोग्रेड मेंस्ट्रुएशन को हम और प्रमोट कर रहे होंगे। मैं इस पेशेंट में बिल्कुल भी HSG नहीं करना चाहूंगी।
मैम मुझे इसीलिए लगता है कि इसका करा गया होगा, मस्ट भी डायग्नोस्टिक लैब की गई होगी, साथ में थेरेपेटिक उसका सिस्टेक्टमी कर दिया गया होगा।
अच्छा, एक चीज IVF में मुझे एक चीज और बोलनी है, if we are going for an IVF cycle in such a patient, so during stimulation what is different and additional is that the dose requirement of endometriotic patient might be little higher. You know, usually if a dose of 150 we are giving, maybe we'll be giving 225. Additional dose sometimes is required because the follicles might be little more stubborn. And also after retrieval, I personally go half IVF, half ICSI rather than all IVF in these patients, because there might be sometimes you might not get still on 0 eggs. So ICSI should be done in endometriotic patients.
For third and fourth stage, ICSI is the right thing. Anupama, here I don't agree with you. When we are planning IUI, it is very important for us to see. And most of the time we do on the HSG on 7th to 10th day. If we are doing IUI and we don't know about the status of tubes, then we are in this thing, dilemma, whether the IUI will be successful. Naturally, we have to go after IUI करने के बाद हमको जाना ही है IVF पे. But when we are giving trials,
it's okay, ma'am.
Anyways, it's always learning. It is always learning few points. Great.
Now, moving forward, ma'am, here we have a case of 40 years old female. Her main complaint is just dysmenorrhea. She is having 2 children, both by LSCS, and in her past history, she has a history which is suggestive of some cyst removal for infertility, and she has conceived after that. There are no previous records available. Her CA-125 is 87 international units, and in her ultrasound, we have got a 4 centimeter endometrioma in the left ovary. Previous to LSCS and history of one-time cystectomy done, ma'am. How will we proceed with her? I think anyone can...
Is she desirous of a issue?
No, ma'am. She just, her main complaint is dysmenorrhea, ma'am.
Now, in that case, if her main complaint is dysmenorrhea, and then we just have to manage her symptomatically on that. So give her, we need to manage the pain with NSAIDs. If you have what you said, 4 centimeters endometrioma.
Ma'am, history of some cyst removal, ma'am, and she has conceived after that. Sometimes we have patients who don't have any records available with them. So that's why I've taken up this case, ma'am. She's just telling that she was having some history of cyst removal, and she has conceived after that.
So, see, 4 centimeters is just like the upper stage, you know, so the cutoff is usually 3 centimeters, which they say below 3 centimeters, do not do any surgeries, and above 3 centimeters, you can think of a surgery. But even at this stage, with so far as I am concerned, I will give her a medical management first with analgesics and see if she can be made pain-free with this medical management is fine. She can be always, the medical management, I don't really just mean Dynogest. As has been mentioned repeatedly, LNG intrauterine system works fantastically in these women. So if we can, since she is not desirous of further children, inserting an LNG intrauterine system would not only take care of her pain, would also take care of her endometriosis, delay the progress of endometriosis.
Thank you, ma'am.
Yeah, I think because in this, symptomatic treatment can be given.
Is the symptomatic
if we have to avoid her surgery, she has already been taken for 3 times. She has been undergone surgeries, and like a patient can be given NSAIDs, you know, etoricoxib. If she is not pregnant, then this group helps more. And if she and mefenamic acid, simple ibuprofen, this will help. And then like LNGS, IUG, that could be placed in that patient. I think that could be the line of management.
Yes, and even doing the surgery on the same side of the ovary could be a little bit, because there may be adhesions will also be there.
Yes, because pain is something you cannot just put it on endometrioma. She has had 2 LSCS. It could be because of adhesion. That is something, it is very individualized. Pain has to be quantified according to the patient. So in that way, symptomatic approach will be better in such type of patient.
Sonam, can I interfere, Sonam?
Yes, ma'am.
There is a pain scoring system by
Yes.
Dr. Cleland. And for this case, we have to score all the 13 questions. We have to ask the patient, and we have to score the pain, which is the score for the patient 1 to 3 or 3 to 5 or 5 to 7. And accordingly, we have to treat for the pain management. As Dr. Jyotsna said, pain may be due to the adhesions. So we have to go the pain scoring system also.
Thank you, ma'am. Thank you for the inputs. Now, moving forward, here again, a same patient of reproductive age group, 23 years old female, who has been married for 6 months, and she has come to the emergency with complaints of acute pain abdomen. The ultrasound showed a huge mass on the right side of the ovary, like it may be a right ovarian mass, 9 into 10 into 11 centimeter. Left ovary is having a simple cyst with mild ascites. CECT, we have got almost the same findings, but it has showed the cyst is multilocular, thin septate with no solid areas are seen. Her CA125 is quite high. It is 5,000. So I would request Jyotsna ma'am to take up for this case. Ma'am, what can the differential diagnosis for this cases, and how shall we proceed further for this young female?
Yeah, thank you, Dr. Sonam. I think this is something very common which we get. A 23-year-old recently married presenting with acute abdominal pain. I think if we just stick by this, the first DD is like ectopic pregnancy. She has been recently married. So for every female young reproductive age group come with acute abdomen, we need to know her LMP, we need to do her urine pregnancy test. And then we have to first rule out that there is whether she is pregnant with acute abdomen with pregnancy or acute abdomen with no pregnancy. Then we are giving the ultrasonological findings. See, once the ultrasound is one of the important diagnostic tool nowadays. It will help us rule out the pregnancy also, and also it will help us rule out, because you are saying she is having mild ascites also. So we have to really see whether it is the domain of a gynecologist or there is some amount of peritonitis involved or peritoneal cyst involved. So it helps us in differentiating that. But we will stick to our branch. So we'll take it. Now she is having a large mass. Ovarian mass, what you have said is like something in the range of 10-11 centimeter. Now what can happen? It could undergo a torsion. Then there can be some, it might have been more larger and it has gone, it has partially ruptured, or it's in the process of rupturing. So that is something which should come in our mind. So ectopic could be is the first diagnosis, and second we come to ovarian torsions. Then of course there can be then you are saying on the other side there was a simple cyst with mild ascites. So we need to see if there is any intestinal obstruction or intestinal the acute abdomen is because of that, and the ascites is because of the peritonitis. Then CECT confirms the findings, and the CA125 here is very high. So there is something now which is in a young patient, they have actually thrown that she may be having some sort of ovarian malignancy. And as we know, CA125 is mainly raised in epithelial ovarian cancers. It is the marker. But then again, it is more of a prognostic marker than a diagnostic marker. But in this case, I think with ultrasonography, a color Doppler should be done. The RMI value should be taken. CCT is there. CA125 or 5,000 is a really, really high CA125. So neoplasia is something which I would really like to take into consideration. Cyst adenocarcinoma is something which is seen in the young age group person. So that is something we really need to be there. And of course, since we are sitting in endometrioma, in endometriosis also it is said if the cyst is more than 6 centimeter, then there is very less chances, 1% chances, but it is also seen in association with the carcinomas, epithelial carcinoma. So here may be the case in which we are dealing with something overlapping things. So there is neoplasia definitely need to be ruled out, and she might also be having some intestinal pathology. So I'll probably make my DD like this only: ectopic, ovarian torsion, ovarian rupture, then malignancy, ovarian malignancy, then any intestinal pathology with secondary peritonitis. I think I will proceed this case like this. This is how I'll.
Thank you, ma'am. This case actually I've taken from the case discussion of when I've attended endometriosis panel discussion. This is actually a true case in this young girl presented with this.
Yeah, we have management, but we can also discuss like other tumor markers. And since she's having an acute abdomen, so this is like an emergency. So the modality of treatment could be like, see, she's a young patient. If she had been, like ma'am said, Dr. Miss, and if the family would have been completed, she would have been a married person with the 2 kids or 3 kids, then straight away exploratory laparotomy with whatever proceed may be there. But she is a young patient, recently married, fertility issues is definitely there. So we can go for laparoscopy, diagnostic laparoscopy, and we
Laparoscopy
can
was
do
done for this
anti-diffuse
female.
cytology, and if possible, like, then of course the place where we are doing this case is very important. But she's in emergency, we have to do it. Frozen section, if we can do it, just to rule out malignancy part. So laparoscopy / exploratory laparotomy would be what I would suggest as a treatment for her acute.
For this patient. Yes, ma'am. And actually, this patient in laparoscopy, the frozen section was negative, and also on inspection, there were no epithelial growth or anything. It was mild peritonitis only. Thus, actually, the large endometrioma was going in for torsion. So that's why this patient came up with this acute pain abdomen, and rest of the tumor markers were normal, and the cyst histopathological examination also showed an endometrioma. And because I have taken this case purposefully, because in this she was having a very high values of sorry.
So in this case, post-op follow-up is also important. That's what I understand. If it is a clear-cut case of endometrioma, then of course debulking or excision must have been done.
Cystectomy was done for this case,
Yes.
And in this case, one unusual thing was that CA-125 was quite high for her age, and this. That was only one thing.
It can be because of reactionary, because once the chocolate cyst comes out and it coats all the intestine, this is some reactionary we can have. So CA-125 could have been should have been followed in subsequently. We could have done it, and maybe in time it would come down also. Endometriosis also, but it will not be that raised. It will not be in thousands.
Thank you, ma'am. Now moving forward.
I have an input here.
Yes, ma'am.
Endometriosis, endometriomas are the adnexal masses which are less likely to get into torsion.
Yes, this was something which
is
all
adhesions there.
Yes.
Yeah. And अगर malignancy है तो उसकी वजह से जो मास बनेगा उसमें ovarian torsion होने के chances ज्यादा है.
This case was
he had
actually
acute abdomen because of torsion.
That's why I've added this case here.
ये ना एक MCQs आता है कि which of the ovarian cysts, they do not get torsion. उसमें endometriomas are the answer, if you remember. The reason given is that because there are too much adhesion. जो endometriosis होता है उसमें adhesion बहुत हो जाता है, इसको kissing ovaries वगैरह मिलती है. But these are unusual findings. So if you have taken a real case scenario, then this is something that
this is a real case scenario, ma'am, of
so
some senior doctor I'm not naming.
We should learn from it. These are the rare cases, which the presentations are also like not typical presentation. So
and endometriomas are not multilocular too. They are mostly unilocular.
Unilocular, yes.
Mostly
ground glass होता है उसमें. Main चीज होती है कि ground glass दिखता है. ऐसे clear cyst जैसा नहीं दिखता है. So that was the
multilocular is very rare.
नहीं हो सकता है multilocular अर्चना, ऐसा नहीं है. बहुत बार multilocular मिलते हैं, but उसमें आपको ground glass मिलेगा.
Loculi. Otherwise, they are. 2-3 endometriomas are coming together and they are forming a loculated cyst-like appearance.
मिलेंगे अर्चना, मतलब loculated ऐसा नहीं मैं कह रही हूँ कि मिलेंगे, बहुत बार मिलेंगे तुम्हें, लेकिन important बात बस यही है कि उसमें सारे ही clear cyst होंगे. मैलिग्नेंसी में क्लियर सिस्ट ज्यादा मिलेंगे और एंडोमेट्रियोमा में आपको 1-2 में तो जरूर ऐसा मिलेगा कि आपको ग्राउंड ग्लास मिलेगी.
ग्राउंड ग्लास
यही कैच है.
हम हिस्टोपैथोलॉजी ही डायग्नोस्टिक बना इस केस में अगर देखें तो, अदरवाइज तो आप मैलिग्नेंसी
की तरफ इसके सारे फीचर्स थे मैम.
बॉर्डरलाइन वी कुड से बॉर्डरलाइन अदरवाइज.
मतलब केस अच्छा था.
हां, बॉर्डरलाइन केस है.
इंटरेस्टिंग केस था रियली. CA-125 has to be followed.
Has to be followed. Yes.
Now moving forward, ma'am, यहाँ पे we have a 60 years old female, post hysterectomy done. Now I don't know why the hysterectomy was done. She has some complaints of AUB 15 years back and no records available. She has complaints of pain abdomen on and off all over abdomen, non-specific pain. On the routine ultrasound, it showed a 6 centimeter cyst in the left ovary, query hemorrhagic, query endometriotic. Ma'am, how will we proceed further with her? I would request Archana ma'am to kindly proceed with this case, ma'am.
Thank you, Sonam. Thank you, Dr. Jyoti and Dr. Asha for having me here. And I would congratulate Sonam. You have included very interesting cases covering almost all the endometriosis.
Thank you.
So in this case, because she is a 60-year-old female, that too post hysterectomy, and this hysterectomy was done 15 years back. So she must be about 45 years at that time.
45.
So I think her oophorectomy was not done along with. And what first comes to my mind is definitely a malignancy. And we have to rule out a malignancy in this case. But here, interestingly, because what we think is menopause comes with end of endometriosis. And I think what this case means to that post-menopausal endometriosis does exist. So we have to think of post-menopausal endometrioma too, because I think they are saying query hemorrhagic, query this thing endometriosis. That means ultrasonological findings must be in favor of hemorrhagic or endometriotic cyst, because they have not given other things. So in this case, I would definitely rule out malignancy. I would go for a IOTA classification of the of this cyst. I would like to go for a MRI also for some tumor markers too, like CA125 and CEA, your AFP, Roma. I would like to exclude. And then if it comes to in favor of endometriosis, see, in postmenopausal patients, endometriosis does have a malignant transformation also. So we have to keep in mind of this also. So in this case, I would go for a surgical management because she's already 60 years old. She needs to take out her ovaries, both of them, because somewhere the estrogen is being raised. Because even if it is a ovarian malignancy or it is a endometrioma, then also this is suggestive of high estrogen in this case, because most of the most of the causes of endometriosis and that of malignancy, they are the same. I would like to know whether this patient was on HRT or not after she was hysterectomy was done.
No, ma'am. No history of any drug intake. Her complaint was just pain, abdomen, and that too, ma'am, it was very diffuse. Diffuse all over abdomen.
So after ruling out and doing for a surgical management, if it is endometriosis, I would like to sweep off all the small deposits which she had. And then definitely I would like to follow with medical management. If there is any contraindication for surgery, then only I will go for a medical management first. Otherwise, surgery is the best choice in this case.
Thank you, ma'am.
She's 60 years old. So keeping in, and the cyst is more than 5 centimeters. So we have to keep in mind more chances of going in favor of malignancy. Though the ultrasound is showing the hemorrhagic cyst, we have to do all the iota, we have to consider all the iota parameters, as Dr. Archana is telling. And I think surgical management, we should go for the surgical management as the right choice. And CA125 we have to do in this particular case, which we have not, which has not been done here. So
I would like to go for other tumor markers also, ma'am. Not only
other tumor markers. Complete tumor marker profile should have been done for this.
Yeah, very true, very true, very true.
Thank you, ma'am. Thank you for all the panelists and experts for putting in their opinion. I would request Meenuvash ma'am to have an expert comment on endometriosis, ma'am.
Beautiful, beautiful presentation, and all the panelists are very well known. And thank you very much, Dr. Asha Rao, if she is here. Dr. Jyoti, you are a wonderful person. I met you in Lucknow. I said that was a great meeting. Very loving and very smiling person. Anupama is always a favorite. Very knowledgeable. And all the girls, Sonam, Jyoti, Archana, Dr. Nivedita, and Anushiri, and anyone I am forgetting, they are just close, very close to my heart, and wonderful. Dr. Anu, good to see Dr. Anu Chawla here, and Dr. Reena Singhal. Good to see you all. So lovely, lovely webinar, and That's a beautiful part. And Dr. Anupama has told everything, that the menstrual bleeding at the time of neonate bleeding, it's a very important sign that later on this girl is going to have endometriosis. So we have to consider all the things because of the changes, lifestyle modification, and what we see, the plastics are being used because of the environmental factors. All the environmental factors, the more and more cases of endometriosis we are seeing, and we should not take adolescent girls lightly. Initially, we used to have, whenever there is a pain, the mother used to come. She doesn't want to school. She doesn't want to give exam. She's having pain, and even the physician says she is functional. So it is the duty of the gynecology, we, all of us, that we take it. We should have suspicion. Suspicion is the most important part. First we suspicious, then only then we can think of endometriosis, and we have to manage it. So wonderful webinar and wonderful panel discussion. Dr. Sonam, you are a wonderful girl. You have taken cases very judiciously, and all the considering all the age groups, and very well done, Dr. Sonam. And again, congratulations for the Manyata certification for you. That's a good girl. She's giving training to in Kashipur and other states, other places, nearby places, to all the obstetricians, and that is very important part. So congratulations, Sonam, and love to see all of you. And I think that's a thing. And in different age, we have a different parameters, different requirement. In infertility, it's very important. Now the criteria is, don't go even for this thing, endometrioma more than 5 centimeters. You need to, unless and until there is interfering in the ovum pickup, unless and until there is a severe pain, you need not to go for laparoscopy. You can go for ART treatment, and we have to do AMH level, and doing the surgical management, it further reduces the AMH. So better to do without interfering, without touching the endometrioma. We can do the ovum pickup, and we can go for IVF and ICSI treatment for our infertile patients. So thank you, everyone.
Thank you.
Love you all.
Thank you, ma'am. Thank you, Jyoti ma'am, for informing us, ma'am.
Actually, this awareness is just because to raise the suspicion in all the general public, in the doctor, because what mind knows only we write. If you are not knowing anything, you will not doubt anything. The absentees from the school, absentees from the sports, absentees from the going social function, this is all the high suspicious points you have to pick from the students. And I really thankful for everyone. And this Prayaas webinar we started in the COVID time actually. And this is the non-FOXY webinar and just for the patient awareness. And we started in the corporate hospital but they are having the this particular means they are the patient oriented for their class of patient. They made these videos and everything, but we pick up this platform for our own purpose also to give more talk on the different topics for the YouTube lives. And any one of you, if want to use this platform, anytime you can contact us. And I'm so thankful for the Asha Rao madam, who, even knowing this is the private platform, she agreed for this talk. And Dr. Anu Chawla, Dr. Ginni Gupta, Dr. Sonam, Dr. Meenu Vash madam, Dr. Archana Singh madam, Dr. Nivedita Datta, Dr. Anushri Rawal, Dr. Jyotsna Agrawal, Dr. Anupama Futela, Dr. Reena Singhal. And Dr. Anupama, I have been with you since so long in many webinars, and I know what the depth of your knowledge is, because whatever point you pick, you are so well read, and you are having all the actually references also. You can tell about the references also. That was the best part.
I am very poor at it.
Most of the time, even Reena madam, Jyotsna madam, everybody, Anushri, everybody knows, Nivedita, everybody, even we know every bit of thing, but you explain it with the references. What I means since last 5-6 years, I'm observing you. Yes, Anushri?
I would like to add, ma'am, very hats off to Dr. Sonam and you, that it is so much well conducted in time, and we are finishing also in time.
I told Sonam, okay, I don't want so much in-depth knowledge, just which we learn and unlearn. Yeah, I just want the practical tips, and I want practical tips and adolescent too. menopause. This is our criteria, and just the take-home message should be very clear. Those who are seeing this webinar, they should know what to do, what not to do. Just this is the thought.
मेरी लाइफ का ज्योति ये पहला वेबिनार है जो टाइम से खत्म हो रहा है, टाइम से पहले।
Thankful to you. You all are so precise. You all are so precise.
और फिर भी मैम ने बहुत बढ़िया बताया, मैम को पूरा टाइम मिला बोलने के लिए भी और बताने के लिए, एक्सप्लेन करने के लिए, तो हैट्स ऑफ टू द पंक्चुअलिटी. आई एग्री.
Anushri, actually we all know each other and बहुत elaborated, बहुत सारे उनका resume पढ़ने में time waste करने की जगह 2-line resume पढ़ना is best policy. And content is the must. Means content should be good actually. And
I'm that's so a great happy Gudi Padwa to you all. Going ahead with that.
Thank you.
So good to see you, Meenu ma'am.
Shall I click one
photograph? Love you all.
I am clicking one photograph.
Right.
Dr. Jyoti, before conclusion मैं एक चीज दोबारा से बोल दूं. सारी societies please जो अभी आशा राव मैम कह रही थी, since I am part of endometriosis, I'm just carrying her message again forward कि जो भी endometriosis awareness programs हम लोग अपने एरिया में कर सके. मीनू मैम की सोसाइटी में तो हो चुका है, पर बाकी सोसाइटीज में भी अगर आप जो भी छोटा छोटा येलो थीम पे मैम ने बनाया है कि
येलो थीम में ही बैठे हैं.
हम आज देखिए पूरी येलो साड़ी, तो आज से फास्टिंग थे तो
you all are sitting in yellow today, ma'am.
Yeah, we thought
I was in yellow, but I'm in labor room now. I was in yellow.
अभी सोनम तो लखनऊ में मेरे रूम के पास में ही थी, and I जब पर्सनली
screenshot is shared somewhere, people will know this is the yellow ribbon group.
And actually Dr. Nivedita Datta, she advised me the names. Actually I asked her कि ये मुझे webinar करना है और इतने टाइम में करना है, तो she was the person who told me ये लोग हैं. And thank you.
मैम यूके एसओजी में आप एक को पकड़ लीजिए, वो सारे आ जाते हैं.
नहीं मैडम, कई बार
yellow flowers and the green set.
हाँ, you approach Dr. Meenu Vash ma'am and then she'll make everybody
बहुत बिंदास है हमारे अर्चना भी और मीनू मैडम भी. सब
मीनू मैडम तो अभी मतलब जेम ऑफ पर्सन है. मीनू मैडम तो
I remember मैंने सबको सिर्फ एक बार रिक्वेस्ट करा था and all were like so more than happy कि हाँ मैम, like though it will be busy for us but we will be doing because we're having so many
रीना मैडम तो मैंने देखा रीना मैडम 4 बजने के 10 मिनट पहले ही आके पूरा सब प्रिपेयर करा लिया, सब म्यूट अनम्यूट सब करके बैठी थी. इवन आई नो अनुश्री, शी इज हैविंग सो small kids, वो भी टाइम पे आके बैठे. This is the great thing.
ज्योति आज सेम टाइम पे 4 to 6 पे एचआईवी कमेटी का वो भी चल रहा है.
Yeah, something else is also going on at the same time.
Next time we will plan जिस दिन कुछ ना होगा. And thank you very much. I am so humble. Thank you.
Thank you. Honored to be the part of.
Thank you, ma'am. Thank you for honoring us. Thank you.
Thank you.
Bye, dear friends.
Thank you very much.